Welcome, my dear nurse friend. Take a moment to settle in. Whether you've just come off a long shift, you're preparing for your next nursing exam, or you're simply here to wind down and drift into rest, this quiet space is for you. Tonight, I'll be softly guiding you through something deeply familiar to every nurse. Something simple, yet powerful, a process that carries us through every patient encounter, one thoughtful step at a time. This is the nursing process, a gentle, flowing cycle of care that we follow with every soul we're trusted to help. It begins with curiosity, it continues with action, and it ends with reflection and compassion. You may know it as ADPIE. A for assessment, D for diagnosis, P for planning, I for implementation, and E for evaluation. But tonight, we won't just memorize the steps. We'll explore the purpose behind them, and we'll do it slowly, kindly, and with intention, just like the care we give. So, as you listen, you don't need to take notes. You don't need to stress. Let this be a moment of peace, a time to feel grounded in your path as a nurse. Whether you're brand new to nursing or have years of experience behind you, we all return to these fundamentals. The nursing process is not a checklist. It's not something we do just to pass a test. It's a mindset, a way of thinking, acting, and caring. In this video, we'll walk through each step, slowly and softly. I'll whisper gentle reminders of what each phase means, with examples and calming explanations. Together, we'll imagine what it feels like to assess someone's needs, to create a care plan filled with intention, to carry out small, compassionate tasks, and to evaluate not just the outcome, but the meaning behind our efforts. This isn't just about nursing. It's about human connection. It's about presence. It's about noticing, listening, and truly showing up for another person. So if your eyes are getting heavy, or if your mind is overwhelmed from studying, know that you're in the right place. You are becoming the kind of nurse the world needs. And this process, ADPIE, is one of the tools that will guide you there. So take a deep breath in and let it go slowly. Allow your body to soften, your thoughts to slow, and your heart to be open. Let's begin now with the very first step of the nursing process, assessment. This is where everything starts. Before we plan, before we act, before we evaluate, we must first understand, and understanding comes from observing, listening, and gently gathering information. Assessment is the foundation of care. It's the process of collecting data about the patient's physical condition, their emotional state, their environment, and even their unspoken needs. You may hear nurses say, "We assess every time we walk into a room." And it's true. From the moment we lay eyes on our patient, the process begins. Some assessments are objective, things we can measure, see, or verify, like vital signs, blood pressure, temperature, heart rate, or skin color, pupil size, respiratory patterns. Other assessments are subjective, what the patient tells us: pain, nausea, fear. These are not visible to the eye, but they are just as real. We ask gentle questions and we listen, not just to their words, but to their tone, their body language, their silence. Sometimes what's not said is more telling than what is. And so we learn to be still, to be present, to let our patient speak without interruption or assumption. You might hear a patient say, "I just don't feel like myself lately," or "something doesn't feel right." These words may seem vague, but to a nurse, they're clues. And so we explore, kindly, patiently. We ask open-ended questions like, "Can you tell me more about what you're feeling? When did this start? What makes it better or worse?" We touch with purpose. We listen with the stethoscope, not just to hear the heart, but to understand the rhythm of their life. We check skin turgor, look for signs of edema, assess wounds, mobility, orientation. Assessment is not rushed. It's not robotic. It is thoughtful. It is the art of noticing deeply. And yet, we follow a structure to make sure we gather information completely. We assess from head to toe, looking at each system: neurological, respiratory, cardiovascular, gastrointestinal, musculoskeletal, integumentary, and so on. We might also use mnemonics like OLCART when assessing pain. O, onset. L, location. D, duration. C, characteristics. A, aggravating factors. R, relieving factors. T, treatment tried. Each answer reveals another piece of the puzzle. We also gather data from other sources: charts, lab results, imaging, family input, even previous documentation. We are investigators of health, seekers of clarity. And when we combine everything we've learned, what we see, what we hear, what we sense, we form a complete picture of our patient. But remember, assessment is never one and done. It's ongoing, continuous, evolving. The patient who was stable at 8 a.m. might not be stable by 10 a.m. Conditions change, and so we assess again and again, with curiosity, with consistency, with care, and in those quiet moments at the bedside, when you take a deep breath with your patient, when you notice their hands trembling or hear their voice falter, you are doing the most human part of nursing. You are seeing them, not just as a diagnosis, but as a person. Assessment, at its heart, is presence. It's showing up fully. You don't need to know everything to do it well. You just need to observe, to ask, to feel, and to care. So whether you're preparing for your clinical rotation, studying for your exam, or reflecting after a shift, let this remind you, assessment is more than a checklist. It's an invitation to truly understand the person in front of you. Take your time, look, listen, ask, feel, trust what you see, and never be afraid to question. Every great nurse is a great observer first. Now that we've assessed our patient with care and curiosity, we move gently into the second step of the nursing process: diagnosis. In nursing, diagnosis doesn't mean giving a medical label like a doctor might. We don't say, "This patient has pneumonia," or "This is appendicitis." Instead, we focus on how the patient is responding, physically, emotionally, spiritually. The nursing diagnosis is about patterns, about identifying human needs. It's about recognizing where help is needed and how the body, mind, and heart are coping. After we collect our assessment data, subjective and objective, we pause, we reflect. What are the problems presenting themselves? What risks do we notice? What strengths does the patient still have? This step asks us to analyze, to synthesize, to think critically. Let's say we assessed a patient who just had surgery. They say, "It hurts when I breathe deeply." We observe shallow breathing. Their oxygen saturation is slightly lower than expected. We might then say, "This patient has ineffective breathing pattern related to pain and shallow respirations, as evidenced by oxygen saturation of 92% and verbal report of pain." That is a nursing diagnosis. Simple, clear, based on what we see and hear. We often use ADPIE language, which helps us stay consistent in our terminology. Some of the most common nursing diagnoses you might encounter include acute pain, risk for falls, impaired skin integrity, anxiety, deficient knowledge, imbalanced nutrition, risk for infection, ineffective coping. Some diagnoses are actual, meaning they're already happening. Some are risk-based, meaning the condition hasn't occurred yet, but the potential is real. and some are wellness focused, used when a patient is ready to grow or improve in some area. Each diagnosis is made up of at least two parts, the problem and the related factors. Sometimes we add a third part, evidence or defining characteristics. This is often called the PES format. P, problem, what's happening. E, etiology, what's causing it. S, signs, tree, symptoms. How do we know? For example, problem, risk for falls. Etiology, related to unsteady gait and use of assistive device. Symptoms, as evidenced by patient's report of dizziness and history of previous falls. By writing clear nursing diagnoses, we give ourselves a focused way to plan care. We can prioritize what's most urgent, what's most dangerous, and what matters most to the patient. But a diagnosis is not done in isolation. It's a collaborative, thoughtful process. Sometimes you'll consult with other nurses, a charge nurse, or a clinical instructor. Other times you'll just pause, breathe, and look at the story your assessment is telling. It's okay if it doesn't come naturally at first. Diagnosis is a skill that deepens with time. The more patients you meet, the more stories you hear, the better you'll become at identifying what needs care. And remember, every diagnosis is a call to action. It's not a label for the sake of labeling. It's a way to say, I see where you're hurting, and I know how to help. This step reminds us that nursing is both science and intuition. It's not just data, it's the heartbeat between the lines. It's knowing that pain isn't just a number on a scale. It's a barrier to healing, to movement, to joy. And so, as we identify our patient's needs, we do it gently. We do it wisely. We do it with compassion. Now that we've made our nursing diagnosis, we are ready to move forward toward planning care, toward setting meaningful goals, toward making a difference, one step at a time. Now that we've assessed with care, and we've thoughtfully identified our patient's nursing diagnoses, we gently step into the next phase of the process. Planning. This is where intention takes shape, where our understanding becomes direction, where the heart of nursing becomes focused action. In planning, we ask a simple but powerful question. What can we do to help this person heal in the safest, most effective way possible? This step is about setting goals and choosing interventions that guide the path to wellness. But we don't plan randomly. We plan with purpose, with clarity, with the patient in mind, always. Imagine standing beside your patient's bed, their chart open, your observations still fresh in your mind. you've identified that they're at risk for falls. You know they feel unsteady, especially at night, and they've shared that they're afraid of calling for help, not wanting to be a bother. So you pause and you begin to plan. We start by setting goals. Not just any goals, but goals that are SMART, S, specific, M, measurable, A, achievable, R, realistic, T, time-bound. Let's take that same patient. A SMART goal might be: patient will remain free from falls during this hospital stay, or patient will verbalize understanding of fall prevention measures within 24 hours. These goals give us direction. They turn vague hopes into measurable outcomes. Some goals are short-term, like pain control in the next few hours. Others are long-term, such as improved mobility over the next few weeks. Once we've defined our goals, we plan nursing interventions, the actions we'll take to help achieve those outcomes. Interventions can be independent, things nurses do on their own, like educating the patient or repositioning them. Dependent, actions that require a provider's order, like administering medications. Collaborative, working with physical therapists, dietitians, or other healthcare members. For our fall risk patient, interventions might include keeping the call light within reach, educating the patient about asking for assistance, ensuring their bed is in the lowest position, using non-skid socks, monitoring them frequently during night hours. We also consider the why behind every action. This is called the rationale. We don't just plan what we'll do, we understand why it matters. Why the bed needs to be low, why we check on them more often at night, why education reduces fear. This critical thinking ensures our plan is not just kind, but clinically sound. Planning also involves prioritization, because in real life, patients may have multiple needs all at once. So we ask, what's most urgent? What's most life-threatening? What matters most to the patient? Maybe our patient is in pain, but they're also at risk for infection, and they feel lonely. We don't ignore any of these, but we plan with priority and compassion, always considering both the clinical side and the human side. In this phase, documentation becomes important. We write our plan clearly in the care plan or chart, so that every nurse, every team member knows the goals and works together toward the same healing vision. But planning isn't rigid, it's flexible. It evolves as the patient's condition changes. Each day, each hour, we reflect and ask, is this still the best plan? Do we need to adjust the goals or try different interventions? And we must also include the patient in the planning process. Ask them, what are your goals for today? What matters most to you right now? Because when care is shared, it becomes stronger. So planning is not just a task, it is the blueprint of care, a quiet, thoughtful act of service. It brings our assessment and diagnosis into focus. It gives meaning to our actions, and it sets the stage for healing. You, as the nurse, are the architect, and every small choice you make in the plan shapes the patient's journey toward recovery. Now, with our plan in place, our goals defined, and our intentions set, we gently move into the next step. We enter the fourth stage of the nursing process, implementation. This is the moment where planning transforms into action, where words become movement, and care becomes real. Implementation is when the nurse steps forward and carries out the interventions designed to support the patient. It is the doing phase, the hands-on expression of all the knowledge, assessment, and planning we've so carefully put together. But even in action, there is gentleness. This step is not rushed. It is purposeful and always grounded in presence. Let's return to our example. We assessed a patient at risk for falls. We diagnosed them with risk for falls related to unsteady gait. We planned goals to keep them safe. And now it's time to put that plan into motion. We walk slowly into the room, softly introduce ourselves, and begin to carry out our interventions. We check that the bed is in the lowest position. We make sure the call bell is within reach. We gently help the patient to the bathroom when needed. We ensure that their nightstand, water, and personal items are all close by. Each action is small, but full of intention. You may also implement patient education during this step, teaching the patient how to use a walker, how to safely move from bed to chair, how to ask for help when needed. And while you are doing all of this, you are still observing, still listening, still connecting. Implementation also includes tasks like administering medications, providing wound care, starting IV fluids, monitoring vital signs, helping with daily living activities like bathing, dressing, or eating. But it's important to remember that implementation is not just physical, it is also emotional, spiritual, supportive. Sometimes the most powerful intervention is simply sitting beside a patient, holding their hand during a moment of fear, or offering quiet words of encouragement. All of these moments, all of these gentle actions are part of implementation. This step is also when collaboration happens. You might work alongside the respiratory therapist to help with oxygen, or walk with a physical therapist during ambulation exercises. You might coordinate with dietary services to ensure a patient receives the right nutrition. You are the bridge, connecting all the parts of care into one seamless experience. And like every step of the nursing process, implementation must be documented clearly and honestly. What interventions did you perform? How did the patient respond? Was anything unusual? Were there any changes? Documentation ensures that the care plan remains visible and accessible to everyone involved, and it allows you to reflect on what's working and what's not. This step also requires flexibility. Sometimes things won't go according to plan. A patient may refuse an intervention. Their condition may change suddenly. A barrier may arise that you didn't expect. And that's okay. Implementation is fluid. It's not about perfection. It's about responsiveness. When something shifts, you pause. You assess again, and you adapt. This is where your clinical judgment becomes your greatest tool. Your ability to stay calm, focused, and compassionate, even in moments of stress or change. Implementation is the heartbeat of nursing. It's where we show up, not just in mind, but in body and presence. It's where we lift, carry, bathe, teach, advocate, and comfort. Every step, every small act is part of the greater whole. And even though implementation looks different from patient to patient, the intention behind it is always the same: to promote healing, to protect safety, to preserve dignity, to honor life. So as you prepare to implement care, take a deep breath, remember your training, trust your instincts, and always center the patient's needs. Now, we come to the final step in the nursing process. A moment of pause, a time to reflect, a chance to ask, did our actions make a difference? We've walked gently through the path of care, from assessment to diagnosis, from planning to implementation. And now we arrive, quietly, at the final step in the nursing process: evaluation. This step is often the most overlooked, but it is one of the most important. Evaluation is where we pause, reflect, and ask with open eyes and an honest heart, did our care make a difference? At its core, evaluation is about outcomes. Did the goals we set actually happen? Did the patient improve? Or did something change? But it's more than just checking off boxes. It's about meaning, about insight, about making sure that our actions were not only completed, but effective. Let's return once more to our example. We had a patient at risk for falling. We set goals to prevent a fall. We implemented actions to support their safety. Now we ask, did the patient stay safe? Did they understand the education we provided? Were they more confident getting out of bed with assistance? If the answer is yes, then we know our interventions were successful. But sometimes the answer is no, and that's okay, because evaluation isn't about judgment, it's about growth. If a goal was not met, we ask, why? Was the goal realistic? Were the interventions appropriate? Did something unexpected occur? Maybe the patient still feels weak walking to the bathroom. Maybe they didn't remember the education because they were too tired. Maybe something new appeared, like dizziness or confusion. In these moments, we return gently to the beginning of the process. We assess again. We update the diagnosis. We adjust the plan. Nursing is not linear. It is circular. It flows and loops and adapts, just like life. And that's what makes this process so beautiful. It honors change. It honors imperfection. It honors the human experience. During evaluation, you are also assessing the patient's response, not just their numbers or test results, but their feelings, their fears, their voice. Sometimes a patient might say, "I still don't feel safe." Even if everything looks perfect on paper, that statement matters, because true healing isn't just physical, it's emotional. And evaluation allows us to hold space for that truth. This step also helps you grow as a nurse. As you reflect on your care, you begin to build wisdom. You start to notice patterns. You learn what works and what doesn't. You discover your own style of care. And just like your patient, you evolve. Evaluation is also about documentation. You write down whether the goals were met, partially met, or unmet. You describe the patient's progress. You make recommendations for the next shift, for the next phase of care. Clear documentation ensures continuity and honors the effort you've made. And sometimes you'll evaluate not just an individual goal, but the whole experience. Did the patient feel respected? Did they feel heard? Did they feel comforted? These questions aren't always measured with numbers, but they matter deeply. In this way, evaluation is more than the last step in a process. It's a form of closure. It's where you and the patient both reflect on the journey you've walked together. You can think of it like this. Assessment is listening. Diagnosis is understanding. Planning is intention. Implementation is action. Evaluation is wisdom. And so, as we end our gentle walk through the nursing process. Take a moment to breathe in and exhale slowly. Let the knowledge settle. Let the calm stay with you. Whether you are a nursing student preparing for an exam, a working nurse seeking peace after a long shift, or simply someone who values care and compassion, know that your presence matters. Your effort is seen, and your heart is enough. Thank you for joining me tonight in this quiet, healing space. May your hands be steady. May your mind be clear. And may your care always be filled with intention. Until next time, rest well.